there should be definitely time at the end for answering additional questions that you have that come up along the way or that I didn't address. These are sort of the latest COVID trends in the Pennsylvania region. In yellow or orange, excuse me, up here are the cases, and in red are the deaths. And you can see we're certainly in a better place than we were during, Delta or the initial Omicron peaks, though there's ongoing transmission of COVID, certainly in our community, but at a lower level than some of these peaks from earlier. There isn't reason currently as to hot spots in our area or across the country. Things seem to sort of go up a little, down a little, up a little, down a little lately, which I guess is better though than when we were having the huge peaks earlier this past winter, for example. In terms of variants, so the main variant, that's circulating obviously at the moment is Omicron, which took over from, Delta. And Omicron was a little different than Delta in that it was generally more contagious, but less severe than what we had seen in the past. Recently, though, we're now dealing with sort of what we call sublineages of Omicron. So these are the BA1, BA2, and currently BA5 is really the main variant of Omicron that's circulating. So this is the proportion of COVID viruses found in the US. And this figure over on the right, hopefully you can see my pointer. Let me know if you can't. This is from the Delaware Valley Basin, Delaware Valley, and BA5 is the predominant variant that's circulating both, locally in Pennsylvania, as well as in the United States in general. And BA5 compared to the other Omicron variants appears to be, again, more contagious in the sense that it can evade immunity. So even if you've had prior infection with COVID or prior vaccination, you can still get infected with it. The severity of those infections, though, it's a little unclear. It looks like it might be slightly more severe in the kind of infection it causes than some of the earlier types of Omicron, but it's definitely still more mild than, say, Delta. So if the severity for Delta was here and Omicron was here, BA5 might be like here. So it might be a small step up in severity, but certainly not as severe as what we saw during Delta waves. It's not surprising that with each variant, the headlines, say that it's more contagious, because what makes a variant kind of take over in a population is how contagious it is. So the more contagious it is, the faster it will spread to other people, and the faster it'll become sort of dominant in the region. So I would expect every variant that comes along to be more contagious than the last. That's sort of where the pressure on the virus is. But the severity, I wouldn't necessarily expect that it will get more or less severe necessarily. I think that could fluctuate somewhat idiosyncratically, which is what we have seen. All right, so in terms of prevention, which is the first general category I'll talk about masking first, then Evusheld, and then vaccines. So in terms of masking, several people said, what really are the rules right now around masking? And looking at CDC guidance, so for the general population, people without an immunocompromising condition, the masking requirements are quite sort of pared down from where they were in the past, where essentially if you either have COVID or if you've been exposed to someone with COVID, then they recommend masking. But outside of that, they don't really make any strong statements about the need for masks. Quite a bit less in the way of masking recommendations than in the past. They do still suggest that for those with immunocompromising conditions, that you wear a mask or a respirator in public indoor spaces, particularly if the area has medium or high COVID community levels. And I'll say it's remarkably hard to figure out what community level any one of us is in. I actually read conflicting reports on what Philadelphia is all the time. And so my usual recommendation, for my transplant patients is to assume there's some COVID still in the area, and to wear a mask when in public indoor spaces. So if you're in an indoor space with people who you don't normally live with, that would be the time to wear a mask. There are not any recommendations about masking really for anybody when you're outdoors. So we really don't see much transmission of COVID when you're truly outside. And so even for immunocompromised individuals, unless I guess you're in sort of a packed concert or something like that, there really aren't any recommendations for masking in that setting. And again, if you're just in your house with your household members, there's no masking recommendation there unless somebody in your house has COVID. So I think that's where we stand currently with masking recommendations. So moving on to sort of the next components of prevention, Evusheld. So there were quite a number of questions about Evusheld, and so I'm going to spend a minute talking about what it is and whether it's useful or not. So Evusheld is 2 monoclonal antibodies against COVID that are injected actually intramuscularly, and the idea is to use them to prevent COVID infection. So it's recommended specifically for people who are over 12 years old who have received a COVID vaccine but may not respond to it due to immunosuppression, or if they have a medical contraindication to the vaccine. So they've had a severe allergic reaction, for example, to their first dose of the vaccine. Now, exactly how this is operationalized varies from program to program. Some programs say, any immunosuppressed person, any transplant recipient should get Evusheld regardless of any potential response to the vaccine. We can't really measure this response very well, so everyone should get it. And other programs, they recommend getting the blood test to measure your antibody response to the vaccine first, and they only recommend Evusheld if your antibody levels are low. I think Penn, for example, does for solid organ transplant, does the first approach where they say any organ transplant recipient or someone who's recently transplanted anyway should just get Evusheld regardless of what their blood tests say. But I know the oncology program at Penn, who sees people who have stem cell transplants, they do the other approach where they check antibody levels first. So I know program to program this differs a little bit, but I think any person who's immunosuppressed is potentially a candidate and so should consider this. Of note, Evusheld is not supposed to be a replacement for vaccination unless you're someone who cannot receive a vaccination because of, again, anaphylaxis, or we'll talk about myocarditis. If you had a severe problem with an initial vaccine dose, then Evusheld may be used in replacement, but otherwise it's not a replacement for vaccination. You actually have to be vaccinated before you qualify for Evusheld. It's also not designed to be used after an exposure. So if you find out that your spouse has COVID, that is not the time to run and get Evusheld. It's never been studied in that sort of setting, and so we don't know if it will be useful at all in that setting. And it's also not a treatment, it's prevention. In terms of efficacy, so there was a clinical trial done looking at Evusheld that included people who are immunosuppressed, because that was sort of the goal, including about 200 people who were on chronic immunosuppression, like a transplant recipient. And they found that it did significantly reduce the likelihood of developing symptomatic COVID infection. Now, it may be, they've looked sort of in the lab at how well Evusheld works against the latest Omicron variants, so BA4 and BA5. And it still works against Omicron in general, though specifically BA4 and BA5, it may be slightly less effective, but it's not as if there's no impact. It still does, to a certain degree, neutralize those viruses. So we still are giving Evusheld despite, the changing variants. So in terms of how it's given, it's 2 intramuscular injections. So as I mentioned, it's 2 monoclonal antibodies that are sort of unpronounceable, the T1 and the C1, and you get an injection of each of those. And so that's what the 2 injections are. It is intramuscular, so it's actually usually into your bottom, which is a little different than I think most injections we get as adults. And currently the FDA recommends redosing it about every 6 months, because that's about how long we expect the antibodies to stay in your system. In terms of side effects, so some of my patients have reported, pain or irritation at the injection sites, which is, not uncommon. The only serious side effect that we're still trying to figure out if it's real or not is that in the clinical trial, where they gave some people Evusheld and some people nothing, the people who got Evusheld, there was a slightly higher rate of heart disease. The myocardial infarction is a heart attack, and heart failure is where the heart doesn't pump as strongly. Now, all of the patients in the study who had this heart disease issue had a history of heart disease issues, and so or significant risk factors for it. And so we don't know yet if Evusheld really caused this side effect, or if it was just sort of a fluke that this happened more in the group that got Evusheld. But given that it's a sort of new medication and this is a potentially significant side effect, this is the main one that I make sure to talk to patients about before getting it. And I will say for transplant candidates or recipients who have a history of, heart disease, I may shy away from Evusheld in that group, though not necessarily. It depends on a number of factors. But if you don't have any significant risk factors or history of heart disease, then I don't worry about this as much, because that's what they saw in the trial. In terms of timing, so if you're going to get Evusheld, the main thing is that you don't want to get it sort of right at the same time as a vaccine. So for COVID specifically, so if you get a COVID vaccine, any dose, whether it's a primary dose or a booster, you need to wait 2 weeks before you get Evusheld. Now, after getting Evusheld, you can get boosters or doses of the COVID vaccine anytime you want to afterwards, but you don't want to give a vaccine and then Evusheld shortly afterwards. And this sort of timing was just recently updated about a week or so ago by the CDC's vaccine committee, ACIP, and so this is the latest recommendation. So if you need both Evusheld and a booster, what we usually recommend is get the booster first, in part because we think it's more effective, then wait 2 weeks and then get the Evusheld. You can get it though at the same time as, or with any timing around flu shots or other vaccines that aren't for COVID. So if you need, shingles vaccine, a flu shot, tetanus shot, you can get those, the same day that you get Evusheld. That doesn't matter at all. This is a slide from the CDC that I'm not going to read to you, but I thought the takeaway was interesting, which is that most immunocompromised people in the United States have not gotten Evusheld. And so initially there was concern that there wouldn't be enough Evusheld to go around, but in fact, we have a lot bigger supply of Evusheld than we have actually people who have requested it or gotten it or had access to it and whatnot. And so if you think you qualify and are interested, you should definitely reach out to your providers to talk about it and see if it's available, because it is not in fact in short supply like we thought it might be. All right, so that is Evusheld. So then the third sort of facet of prevention that I want to talk about is, of course, vaccines, which we could talk about for hours and hours. The latest numbers are that, at least in Pennsylvania, about 71% of adults are fully vaccinated, which means they've had at least 2 shots. And that is pretty close to sort of the national average of about 68%. And I will say this is a big improvement over, I think, the last time I presented, a number of months ago, though, of course, it means that still about a third of the, population is not fully vaccinated, or 30%. The number of people boosted in the United States is even lower. It's about 49%, but again, that's actually quite a bit better than initially when the uptake was very, very low. At least about half of adults are boosted now in the United States. So that's where I think we are now. This graph on the left is breaking down, the population by age group and who's eligible for, each kind of, booster and whatnot. And you can see in general, the sort of vaccinated group are those 65 years and older, where 90+% are at least fully vaccinated with at least 2 shots. And then, about 2/3 of whom have at least gotten 1 booster, though very few have honestly gotten their second booster. Okay, so the biggest topic that people ask questions about with vaccines was what's going on with this new bivalent booster, and should I get it? Is the most popular question. So taking a step back to talk about what this is. So why is it called a bivalent booster? So if you recall, the original mRNA vaccines, the Pfizer and Moderna vaccines, were basically, you're getting injected into your shoulder these little lipid bubbles that have little bits of mRNA in them, and that mRNA sort of genetic material derived from a small piece of the COVID virus, like for one of the proteins. So not at all the virus itself, but just a little tiny bit of it. And that mRNA gets taken up into your cells, and then it turns into that protein, that spike protein, which your cells then produce and show on their surface, so your immune system gets a chance to look at that protein and react to it and form a memory against it without actually having to deal with the real virus, so without actually getting sick. So the mRNA that was used in the original vaccines and the original boosters was derived from the original COVID virus. So little genetic material from the original COVID virus. And with the bivalent booster, they are just adding together some mRNA from the original COVID virus, as well as some mRNA from this BA4 and BA5 Omicron variants. So there's 2 different kinds of mRNA in these vaccines, again, some from the original and some from Omicron. And so basically this will give your immune system a chance to look at and figure out how to respond to the original COVID virus, as well as the one that's circulating more recently. So they've literally, they've included half as much of the original one and added about half of the new one together, and that's basically it. So it's called bivalent because there's 2 different parts. So the bi is, referring to there being 2 parts. But that's all there is to it. There's nothing else that's different about it. It's the same exact way that it's going to be injected and delivered and executed in your body. Really, all they've tweaked is exactly what's in this genetic material. So this bivalent booster was authorized as of just about a week ago. And actually with that, the FDA is no longer going to offer, at least in the United States, the original booster. So if you come in for a booster shot, starting this week, the only option will actually be to get a bivalent booster. Now, if you haven't gotten your original shots, they'll still offer the original shots for your primary series, but all boosters will be with this particular bivalent option. So there's once again a Moderna and a Pfizer flavor for this. The Moderna is approved for 18-year-olds and older, and Pfizer is approved for 12-year-olds individuals and older. Now, in terms of the evidence that supports that this is a good idea to use this, so what the FDA said was that they decided to approve this based on the following. One is that we obviously have a lot of real-world experience with the original mRNA vaccines, and they've proven to be quite safe and quite effective. And we're not really changing too much about this vaccine. There's not some significant new components. Number 2, there have been studies in humans with a bivalent booster that included, instead of BA4/5, the BA1 version of Omicron. And that worked well. It was safe, it was effective. And this change to using the BA4, BA5 from BA1 is a very, very minor change. So there has been testing of bivalent boosters in humans, but it was with a slightly different variant. And then finally, the only actual studies of the BA4/5 bivalent booster have been in animals, mice in particular, where they've given mice these boosters, and it's been, safe and effective in mice. And I know that causes concern, I think, among some people that it hasn't been tested, in large clinical trials in people. But I guess I would say two things. One is that, that's obviously true, but given how quickly COVID has sort of mutated and evolved and how long it takes to carry out a clinical trial in humans, where basically the clinical trial takes too long. By the time we finish a clinical trial, we've moved on to a new variant. And so if we want to keep up with the variants, at some point, we're going to have to switch to being comfortable with using a vaccine based on studies that aren't large trials in humans. Similar to the flu shot, which gets changed slightly every year, but we don't redo clinical trials for the flu shot every year, because again, you can't. By the time you finish the trial, the flu season would be over. It's a similar idea to that. So there is precedent for, for extrapolating from, if you're not changing how the vaccine works, and you need it to be produced quickly, there is precedent for doing it this way. And then I guess the other thing I would say is just that the difference between this bivalent booster with the BA4 and 5 variant versus the bivalent booster with the BA1 is really minimal. And so I think it's this is the reasons for pushing out this booster without a large clinical trial supporting it. Okay, so what does that leave us with in terms of how are we supposed to do this? So they're recommending that the bivalent booster be given to anyone, regardless of the number of prior boosters you may have gotten, as long as it's been 2 months since your last shot. So I'm focusing in here on this red box, which is people ages 12 and older who are moderately or severely immunocompromised. So and in this red box, I have people who have gotten Moderna or Pfizer shots up until now, which I think is most people. So if you're moderately severely immunocompromised, you need 3 shots up front as your sort of primary series. And then again, regardless of how many boosters you've gotten, if it's been at least 2 months since your last shot, then you're due for the bivalent booster. I don't think almost anyone I'm aware of has gotten Novavax as their primary series, but for people who did get the J&J vaccine initially, we do recommend 1 additional dose of the original COVID vaccine, mRNA vaccine, excuse me, not J&J. So you get 1 of the original Pfizer, Moderna shots, and then 2 months later, the bivalent booster. So basically, wait 2 months since your last shot and then get the bivalent booster. That's what's being recommended. And you can get it any time relative to your flu shot if you're going to get that soon. They've in fact, looked at whether it's okay to give the flu shot and this booster at the same time, and they didn't in any way negate one another. So my personal preference, I would probably space them out so I didn't feel completely awful, the next day after getting these, shots, but you could get them even on the same day if you wanted to. Now, if you're someone who doesn't yet count as immunocompromised, the only difference here is that your primary series would have been just 2 shots, but then it's still wait 2 months and get the bivalent booster. So it's not all that different if you're not immunocompromised. All right, so in terms of side effects, there's still rare allergic reactions, which I won't talk about too much. That hasn't changed too much. I think the 2 issues that come up a lot in the questions you all submitted in my own clinic is this risk of heart disease after the vaccine, and then the risk of rejection of your organ. So in terms of the heart disease, which is the myocarditis or pericarditis, which has been observed, so this is where the heart gets inflamed after an mRNA vaccine. So as has been true since I think the beginning of this story, it still looks like it's predominantly a risk in sort of young men in the 16 to 30-year-old sort of range. It usually occurs several days or up to a week after a vaccine dose, and it seems like it happens sort of most commonly after dose number 2 for folks, though with each additional booster, I guess we learn more. It may be more common with the Moderna vaccine than the Pfizer vaccine, though I will say that that's a little hard to parse out. In terms of the rate, though, I think this is definitely real in that some people get myocarditis and pericarditis because of the COVID vaccines, the mRNA vaccines. But in a large study looking at people who gotten the Pfizer vaccine, they found that it occurred about 2 cases per 100,000 people. So if you gave 100,000 people Pfizer vaccine doses, 2 of them would have this reaction. So it's still obviously a very small number. Now this number goes up to 10 cases per 100,000 in the high risk group, the adolescent and young men, but still obviously a very, very small percentage of people. And fortunately, CDC is still sort of, following these patients long term, but the vast majority of cases where this myocarditis has occurred, it's been mild or moderate, and people have recovered in general. I'm sure there's an exception out there, but that's what the majority of people experience. So in some ways that hasn't really changed. So it's still a risk of these mRNA vaccines, but it's not incredibly common. In terms of organ rejection, so this is definitely a tricky issue, and I know it's one that's debated, in our field a bit, and there are a lot of sort of suspicious anecdotes, out there, even among my own patients, where they got the vaccination and then subsequently, a couple weeks later, had a rejection, and it's certainly suspicious. That being said, in the clinical trials where they had transplant patients who were split in half, and half of them got an mRNA vaccine and half of them didn't, there was no difference in the rates of rejection seen between those 2 groups of people. And so in the end, the conclusion, it seems, based on real data, is that there isn't a significant increase in the risk of rejection following vaccination. So I would not worry about rejection per se with these mRNA vaccines. Now, if you are someone who had either anaphylaxis or myocarditis after an mRNA vaccine, then what are you supposed to do? So we don't recommend repeating mRNA vaccination if you fall in one of those groups. And this is where I would say talk to your transplant team about whether one of the other vaccines might be good, useful for you, either the J&J or Novavax vaccine, because they are not mRNA vaccines. And then this is another group in which Evusheld might be particularly useful, since it doesn't have, these side effects and could offer some more protection. In terms of the blood tests to measure protection, I wasn't sure where to stick this in the talk, so I put it here. But there's a lot of discussion about measuring antibody responses to the vaccine to measure protection. And there are, blood tests out there where, they draw your blood and they measure your antibodies against either the real virus or the, vaccine virus or protein. And it can give you some sense of the quantity of antibodies in your blood against COVID. We still don't recommend doing this routinely, though, for a couple reasons. One is that antibodies are just one part of your immune system. And so even if you have no antibodies detected on your blood test, you may still have some protection against COVID after your vaccination. Because of those other parts of your immune system that aren't measured in this blood test. And then very importantly, we really don't know what level of antibodies equals protection. And of course, that's really what people want to know. So you get this blood test back and it gives you some amount of antibodies, and so what does this mean? And the truth is we don't really know. And so even if you have a whole lot of antibodies detected on your blood test, no one can tell you, okay, this means you're good to go. So the blood tests, I think we continue to avoid them, since in the end, our conclusion about risk tends to be the same, which is, you're immunosuppressed, but you've gotten vaccinated. You've probably got some protection from the vaccine, but I can't tell you exactly how much. And that that sort of assessment doesn't really change based on the antibody tests. So that's why we don't use it more commonly. All right, so in summary, in general, we recommend, that in general, the, FDA, the CDC recommends that you get your bivalent booster. This is for everyone except, for those in the asterisk category, which is if you've had anaphylaxis or myocarditis to a prior mRNA vaccine. And as a reminder, you can get this booster anytime after, as long as it's been 2 months since your last COVID shot, anytime after you get Evusheld, anytime before, during, or after your flu shot. You can get it, or you should get it, even if you have antibodies detected on blood tests, and certainly if you don't. Even if you've had COVID before, as soon as you're recovered from COVID, we still recommend getting this booster. Even if you haven't had COVID yet, I'm sorry to tell you, you aren't sort of naturally immune. I don't think there's any such thing that's, anyway, clearly been confirmed to exist, and so we still recommend the booster. You do, of course, I don't want to make sweeping statements for everybody on the call. And so it's always good to double check with your transplant team about getting the booster and the timing. And especially you want to talk to your transplant team about the timing if you're still in the early months after your transplant, especially, those first 6 or even 12 months. If you recently had rejection, or if your immunosuppression changed significantly recently, then you'll want to review it with them. But my guess is that most transplant teams will give you the green light and suggest that everyone get it. All right, so moving on to COVID infection now. So all that other, that first whole section was about prevention. So if you actually get COVID infection, what's new there? So the symptoms haven't really changed. We've seen a general shift in that the symptoms have become less like pneumonia and more like a cold over time, though any of the same symptoms still may be present when you have, so anything from a runny nose to a high fever, some just general fatigue versus diarrhea. Any of these are possibilities. There's not been any big changes in testing recommendations. We still have the rapid antigen tests, including the home tests, and then the lab-based PCR tests, where the PCR tests are a bit more sensitive, but the home tests are a little more accessible. In general, I recommend testing early and often. The sooner you find out you have COVID, the better in terms of getting treatments, as well as sort of isolating and preventing spread. And then we do recommend sometimes repeat testing because, as I'm sure some of you have found out in your own lives, tests, particularly the rapid antigen tests and the home tests, are not always positive right away, even when you've got some symptoms started. And so repeat testing is sometimes needed. In terms of how transplant patients do when they do get infected with COVID, so in general, we see that the outcomes are improving over time. So when we first, at the very beginning of the COVID pandemic, when transplant patients were infected with COVID, we saw on average anywhere between 10 and 30% of them actually died from COVID. So staggeringly high number. But over time, it has come down, and more recent studies estimate about 5 to 10% of transplant patients who are infected die, and some of those patients are, of course, not vaccinated, while some are. And in the general population, the rate's about 1 to 5%. So you can see there's sort of a closing of the gap between, the severity in the general population, the severity in transplant patients. And there've been a number of studies now confirming that when a transplant patient gets vaccinated, particularly with the mRNA vaccines, the risk of dying from COVID does go down. I've referenced the numbers from one study here, where after just 2 mRNA vaccines, so not even the full primary series, the risk of death, went down, almost in half, from 13% to 7.7%. So, and again, that was just with 2 vaccine shots. And we hope that there's even more protection from the additional shots and boosters. So the outcomes, do seem to be improving, and it's probably in part due to Omicron being sort of a less severe virus, and then of course the vaccines, and then also because of treatments, which is the sort of last segment of my prepared slides here. And so we do have a number of options now for treating COVID when you get infected. Now, I wanted to start by highlighting that universally, all of the treatments are more effective when they're started early in the course of infection. So as soon as you think you have COVID, or certainly if you've tested positive, you want to call your team sort of right away to see about treatment options. After about 5 or 7 days of symptoms, if you call your transplant team, actually, you're no longer sort of able to get many of the treatments that you could have during the first 5 or 7 days. So, so you definitely want to call quickly. That's another reason to sort of test early and often, so that you can call your team quickly. This slide sort of lists the treatment options that are available now for outpatients. So if you're not in the hospital because of COVID, you're at home, but feeling, have your runny nose or sore throat or fever or whatnot because of COVID. And so specifically, these treatments are for people who have COVID and have at least one risk factor for progressing to severe disease. And these risk factors, a lot of people qualify for this. So anyone with, significant chronic disease would qualify. It's for people who are not hospitalized due to COVID, though, and not requiring more oxygen, through their nose than in the past. So it's people who are at home and feeling kind of crummy, but not bad enough to be in the hospital. So there's 3 options that are antivirus medications, 2 that are pills, and 1 that's an IV. And then there's a monoclonal antibody option, and I'll talk about each one of these for a moment. So the first one is Paxlovid, which is a pill, and it's been found to be quite effective in the studies that led to its approval. It reduced the risk of either being hospitalized or dying from COVID from 6% to less than 1%. So that's pretty good. And 0 people died due to COVID in those who got Paxlovid. And it has activity against Omicron. But I don't want to dwell on this one too much, because it does have big problems when it comes to transplant recipients, in that there are drug-drug interactions. So one component of the Paxlovid pill will cause your tacrolimus or sirolimus medication level to sort of skyrocket to incredibly high levels. And so we actually don't recommend it for most people who are taking, tacrolimus, sirolimus, one of the calcineurin inhibitors. So if someone other than your transplant team gives you Paxlovid, you do want to run it by your transplant team before starting to use it. The other pill option is this one, the molnupiravir, and it does not have the issues of the drug-drug interactions that Paxlovid does. I will say it's maybe a little less effective in that the amount that it reduced the risk of hospitalization or death in the study was a little more modest. So it reduced it from 10% to 7%. But it does work against Omicron. And again, it is compatible with most transplant medications. The one major issue with it is not okay for pregnant individuals because there's clear evidence that it may in fact cause fetal harm. The other concern, which is sort of theoretical, is that it does purposely cause sort of mutations in the COVID virus. And so there's a concern that if used ubiquitously, it could actually spur more variants developing. But I think, COVID does that on its own. So I'm not sure that's a huge actual concern. Another option to get as treatments if you're, again, at home with COVID is remdesivir, which is an IV, an intravenous medication. It seems to work quite well in reducing the risk of having to go to the hospital or dying from COVID. Again, reduces that risk down to less than 1%. It works against Omicron. The main issue with it is that it's IV, and so it's a lot less convenience, when you're at home in a clinic. And not only is it IV, but you get it once a day for 3 days in a row. And so it means having to go to like an infusion clinic 3 days in a row, or I don't think anyone wants people to get admitted to the hospital just for this. But if you have sort of a pick or a port already, it may be an option, at home. But that sort of limits how useful this is, just because of convenience issues. The other option is the monoclonal antibody. So the one that we're currently using is bebtelovimab. We've gone through a variety of different, antibody options, and as the virus becomes resistant to one, we, move on to another one. This one actually has been studied in transplant patients who have mild or moderate COVID infection, and when they got this monoclonal antibody, only 8 of them were hospitalized out of 49. One did require the ICU, but no one died due to COVID when they got this. And it does work against Omicron, and has some activity against the BA4, BA5 variants. The only issue with this one, it's also intravenous, but it's a one-time infusion and then you're done. And so this is actually what I think we use most commonly, at least at our center, for transplant recipients who are on, tacrolimus or sirolimus, because although you have to go to clinic or the emergency room to get it, you get the infusion, you hang out to be observed for about an hour or so, and then you can go home. And so it's not nearly as bad as having to arrange a daily, infusion, like with remdesivir. Now, if you have to come into the hospital for COVID because you're having trouble breathing, that kind of thing, these are some of the treatments that we use. We use that remdesivir, the intravenous antivirus medicine I mentioned, and we just give a longer course. Sometimes we use steroids, and then sometimes we use these immunomodulators, tocilizumab or baricitinib. These are sort of if you're having a more severe infection, but all of these have been shown to, improve your chances of recovery, reduce the risk of death, and have real data supporting their use. All right, so this is the last of my prepared slides. It's just got a few of the other submitted questions that I don't think I addressed anywhere else. One person asked about a recent test developed at Penn for MS patients to measure antibody and T cell responses to vaccines and whether it be available for transplant patients. So this is a very great question, because what they're getting at is a test that can not only look at antibody levels, but another part of the immune system as well. And it captures more fully how someone has responded to a vaccine and how protected they might be. Previously, this has only been available in sort of research settings and not commercially available. And to my knowledge, it's still not commercially available widely. And so I haven't been able to order it for any of my transplant patients as of yet anyway, but I think it's certainly something that could be applicable to transplant patients, and so could be coming down the line, but I'm not aware that it can be used outside of being in a research protocol as of yet. There's another question about avoiding fungal infections, and I think this is referring to the issue that after COVID infection, there's an increased risk of getting a fungal infection. And so I guess, well, the first thing is, of course, if you avoid COVID, then you avoid that sort of increased risk for the fungal infections. Otherwise, it's hard to avoid fungus because it's in the environment, it's kind of all around us. And so really what you want to do is, if you've had COVID recently and you start feeling as if you've got a worsening cough or other pneumonia type symptoms, you want to just call your transplant team quickly, because the fungal infections usually cause a sort of mild, moderate sort of pneumonia. And it's easier to treat and get rid of the sort of earlier we catch it. So I'm not sure it can be totally avoided, but if you clue your team into your symptoms early, then we can get on it. And there's certainly treatments available for fungal infections. And then finally, is it okay to fly with a mask? So, I think obviously the masking requirements in, planes and whatnot has, gone away since last spring. And so you won't necessarily see too many other people on the plane with a mask. So I think it's, going on an airplane potentially increases your risk of getting COVID a little bit. If you're wearing a mask, particularly an N95, I think that reduces your risk quite a bit. Anecdotally, I have patients who have flown wearing an N95 with COVID. I think if you yourself wear a mask, and particularly one that's like an N95, I think that makes the risk of flying, much, much lower. All right, so as a final reminder, the AST, or American Society of Transplantation, continues to update their COVID FAQs page for transplant. So a good place to look if you have additional questions going forward. And I can stop there. I'm happy to answer any questions that have come up.
Hi, that was really great. And it's crazy how different it was from your last presentation, just because how much has changed and continues to change. So there are a lot of questions, so I'm going to try to go through them relatively quickly. And some you answered in your presentation, but I think it's helpful to sort of reconfirm what you said. And one, I actually had removed it because you were in the process of answering it, but I do want to mention it really quickly about the COVID treatments. So just to reconfirm, as a transplant patient, you should really be talking to your transplant team if you have a COVID infection, even if you're like way out of transplant. It's still important to make sure that there's no information. But generally, it sounds like all of these treatments are readily available.
Yeah, so the treatments are, pretty readily available these days. I haven't run into sort of a supply issue lately. I do think if even if you're far out post-transplants, I guess I would talk with the person who manages your immunosuppression, whoever that might be. So it may not be the surgical transplant team, but if it's your like kidney doctor or liver doctor, whoever it is that follows you and, prescribes the tacrolimus or the steroid, that's who you want to talk to, because they would know about the potential drug interactions, if that's an issue. And it may be that I have had some transplant patients who took Paxlovid, for example. It's not as if no one can get it, but you would want to make sure that it's safe for you before you took it. And not every sort of urgent care doctor or primary care doctor knows about tacrolimus, and that it can be dangerous if it's super duper high.
Yeah. Okay. So someone had asked, are there concerns on taking the bivalent booster with the Vivishield, and then how closely it could be done with the flu or immunization?
Yeah, so I think there's this theoretical concern that if you take Evusheld, too soon after the vaccine, that it could kind of interfere with your immune response to the vaccine in some way. And so that's the reason for the recommendation to, get the booster, then wait a couple weeks and then get Evusheld. Those concerns, though, are mostly theoretical. There haven't been data that show that, like, you don't get any effect from your booster because of Evusheld or something like that. And so I would think of them as complementary, not antagonistic. I do think spacing them out somewhat makes sense, by at least 2 weeks. And if the timing is okay, you could space them out even a little more. I feel like our recommendations for this have changed so much over the last few months, anywhere from a couple months to a couple weeks. But I would think of them as complementary. I would probably prioritize the vaccine over Evusheld, just because we've seen more benefit from vaccination than Evusheld in general. But I will say that's sort of my personal take. I think actually, the CDC would agree. The flu shot, I don't think it's not going to mess up your COVID immunity in any way or your protection. It's mostly that you'll just be adding more side effects. So if you get, the COVID shot and the flu shot, you might feel extra crummy the next couple of days. And so again, it's not a serious risk. It's just, you know, the side effects and how many you'll have if you take them all at once. Mild side effects, I mean, like feeling run down. Yeah.
And then the next question, I'm going to try to combine in a way. And just to clarify, so for an immunocompromised person, which a transplant patient would be considered, whether they're mild or severely immunocompromised, a transplant patient is immunocompromised. It's recommended that they get the 2 vaccine shots plus 2 boosters, and potentially, right?
Yeah, so well, we recommend, the official recommendation, if you've been trying to get everything, was there were 3 initial shots actually. So not 2, it was 3 initially. And again, I'm talking about Moderna and Pfizer here. So that's what most people are, I think, talking about. And then there were 2 boosters of their old vaccine, and now there's a 3rd booster. So this could be your 6th total shot, this bivalent booster. And even if you've gotten 5 prior shots, it's still recommended you get the 6th one, as long as it's been 2 months since your last one.
And the 6th one is the bivalent one.
That's right.
What it is. Someone asked us if that's available now. So that is what they're using solely.
Yeah, and I know I have patients who have successfully made appointments at like their local pharmacy for the bivalent one this week. So I think it's out there. You can get it.
So regardless of whether you get user shield, the recommendation is you get those vaccinations.
That's right, unless you have sort of a, like, you know, anaphylaxis, myocarditis, some other contraindication to the boosters.
Mm-hmm. So someone asked about moderately or severely immunocompromised. Like all transplant recipients are considered immunocompromised, but is there a difference between moderate or severe? Like how would one?
So there isn't any difference in terms of the vaccines recommended. And organ transplant patients definitely fall into that category of moderately or severely. Yeah, I think the sort of more mildly immunosuppressed refers to people who, you know, maybe have like an arthritis that occasionally flares up and they occasionally take some prednisone for on and off, but it doesn't refer to folks who sort of day in and day out take multiple, you know, medications for immunosuppression, if that makes sense.
Yeah, so regardless if you're a transplant patient, you're considered immunocompromised and you fall under the category of the booster.
Yeah, even if you're on pretty little immunosuppression at this point, you know, if you've been out, you're out post transplant many months or years.
Yeah, so someone had asked, and I don't know exactly what they mean by it, but I'm going to bring it up. We're talking about vaccines and boosters for the last few minutes. So if you haven't received any boosters, but have received the initial vaccine, still the recommendation of your transplantation is to give your transplant team to potentially increase your production.
I say that, so if you've gotten the primary series but no boosters, what's the recommendation?
Well, it says what should they do, but I'm assuming that means the recommendation, which is to get the booster.
Yeah, so then the recommendation would be to get a booster and the bivalent booster. Yes, but just one, I guess, at this point. And then we'll have to see what they recommend next.
Yeah. So this one I also think you're not going to really know how to answer, but I do want to bring it up. So if you're wearing an N95 and are exposed to someone with COVID, does that increase or decrease your chance of becoming infected?
Yeah, if you're wearing an N95, that really definitely decreases your risk of getting infected. You know, I have, gone into rooms of patients with COVID many times over the last couple of years and wearing, an N95. And I guess the other thing, I wear something over my eyes, but, I haven't ever gotten COVID, in that setting. So the, N95s are extremely effective at, preventing getting COVID infection.
Okay. And is there still a risk on surfaces, like from contracting COVID via surface?
Yeah, I think that that is much less of a concern at this point. I mean, I can't, I don't know if I can say it's like a zero risk, but it seems like the main way people get it is by sort of, face-to-face interactions with someone with COVID, without masks on. But yeah, just sort of touching a doorknob or an elevator button, something like that in a, public place, that doesn't seem to be where people are catching COVID. So I don't worry too much about that. We've done away with a lot of the sort of extra cleaning type procedures that we had done early on without any big change in, how things are going.
Do you have a few more minutes?
Sure.
Okay, there's still a bunch of questions, and I do want to mention, if you ask questions in the chat, I am missing them because the chat moves like pretty quickly. So if you have questions, please put them in the Q&A, and we'll try our best to get through what we can. So someone asked, are all the monoclonal treatments for kidney patients, or are there some for pre-transplant, some for post, or are they all for post?
The monoclonal antibody treatments. Yeah, so those are potentially available to anyone with COVID who has at least one risk factor for developing severe COVID. So definitely could be appropriate for someone who has not yet had a transplant. So any transplant patient, it's, probably, or some treatment is indicated, and anyone who's probably on a waiting list for a transplant, it's probably also indicated, because just having, one organ that's not working well is probably enough of a risk factor that you would qualify for one of those treatments. Now, if you haven't had a transplant yet, you're probably not on tacrolimus or sirolimus, in which case you might be able to do a pill option, which is just kind of simpler. But no, those monoclonal antibodies are available to people even before transplant. I guess the Evusheld specifically is also available to people with immunosuppressing conditions, even if they haven't had an organ transplant. So if you're pre-transplant but on immunosuppressants for whatever's causing your, or for whatever reason, you may again qualify for Evusheld.
So someone asked about if you're immunocompromised and signing indoors, and whether that would be just not suggested or recommended.
Yeah, I mean, it's hard. I think anyone, any indoor activity where there's other people around, who aren't in your household, means that there is some risk of COVID. It's hard to quantify. Initially, we thought it, like, indoor dining was a huge source of like COVID transmission, because there were a lot of sort of anecdotes of outbreaks in that setting. Lately, it's become a little less clear, I think, but I think there is some risk to indoor dining. But obviously it depends on a lot of factors, like how well ventilated it is, how many other people are actually in the restaurant. If it's just you and one other table of people, it might not be such a high risk. So it's a little hard to quantify per se, but yeah, I think in the end, the party line is still that any sort of indoor activity without masks on carries some risk.
Now, how about cyclosporin and Paxlovid?
Cyclosporin and Paxlovid. Okay, so it doesn't necessarily, it's not, the drug interaction is not as severe as with like tacrolimus, and so it's potentially doable, but it would depend a bit on some other factors, like the dose that you're on, and like kidney function and some other things. So you could ask your provider who prescribes cyclosporin if it's okay for you in particular. It's not like an absolute no.
About exposure and all. So as far as working goes, like would it still be generally recommended that like a transplant patient or immunocompromised person could work from home if they can? And then how about like utilizing public transportation?
Yeah, I mean, I think it depends a bit on, your job and everything. I mean, I think that we do we have found that wearing masks really does work pretty well. So if you work in a setting in an office where you can wear a mask, or if you wear a mask on public transportation, I think that reduces the risk quite a bit, such that it's not, incredibly high or anything. And so yeah, I think most people who, um, you know, uh, work in person but wear a mask, do not get COVID at work, I guess, or from the train, or the bus. And so I think, yeah, if you're able to mask, then, it's potentially doable. Working from home always, reduces the risk even, further. But yeah, we don't see a lot of cases, that occur when people are wearing a mask, basically.
Yeah, and of course, everyone's situation is different, so certainly not your opinion about that. So someone asked if that the FDA maybe didn't recommend, I believe, somebody's friend is
Yeah, remdesivir. Okay.
under GFR 30. Is that still the case?
Yeah, so that is, the last I checked, that is still the case. And so I think probably a different, medication would be recommended if you do have sort of low kidney function. The kidney function doesn't matter for all the medication, including like those monoclonal antibodies. It doesn't matter. So there's other options if yeah, you fall in that group.
Okay. And just to clarify one more time, can you, and maybe it's helpful to show this slide again, the one that shows like the time between shots?
Yeah, sure. Yeah, that seems to be definitely the most popular question is how are we supposed to make this all work? All right, let me see here.
And while she's pulling that up, I do want to mention someone asked about using COVID positive donors and their outcomes. So we are not going to talk about that today. However, we did do a program on with the Gifted Life Donor Program where they talked a little bit about COVID positive donors for transplant. So if you're interested, you can email me and I can send you the link for that program.
Yeah, that's a really hot topic in the field right now. So yeah, this is the diagram for the vaccine schedule, where the bottom line is even if you've had up to 5 prior or 6 or however many prior shots you may have had, we still recommend the bivalent booster. And you just want to wait though 2 months after your last primary shot or your last booster shot. So that's the only timing sort of consideration.
And then the flu shot could be done at any time in that process.
Yeah.
And then if you're also getting the Evusheld shot, where would that fall?
Yeah, so the only thing there is you would want to wait after you got, probably if you're ready for the bivalent booster and Evusheld, you would want to get your booster first, the bivalent booster, and then wait at least 2 weeks, maybe like 3 or 4, if you are up for it, but at least 2 weeks and then get Evusheld. That's how we generally recommend doing it.
Okay, so for anyone who asks when you should get what shot, here you go. And then since it's recorded, I can send it to you if you need to or want to review it again. And of course, talk with your doctor. Because they're the ones who are helping for you. So just very few more questions. So would you qualify as an infectious disease physician? Are we in an endemic now? Are we still in a pandemic?
Oh, yeah. That's a good question. We're certainly moving towards sort of an endemic scenario where there's some amount of COVID all the time, and it just fluctuates. So I think people are starting to think of it more as endemic rather than, in the initial pandemic phase.
Yeah, and I want to mention also is interesting. I've worked here with transplantations for 12 years now, and pre-COVID, the recommendations, especially around flu seasons, flu season was very similar to what it is now, which is transplant patients should really mask to protect themselves, especially in group sick people. So we're not really that far from what it was pre-COVID for transplantation.
Yeah.
And with flu season coming up, and last year COVID being very high, do you see, or is there an expectation of maintaining in
An expectation of what now?
high rates of COVID again?
Yeah, so it's a good question. There's certainly concern that going into like the fall and winter, that we will see another surge. Because people start spending more time indoors, and there's more, kids are back in school, and all the the togetherness that results in. There is not, to my knowledge, like a new variant in another part of the world that's just skyrocketing that we expect to come and skyrocket here as of yet. We continue to look at like Europe and South Africa and see what's happening there, but I think part of why they did push out this bivalent booster for the fall is to try to improve immunity going into the fall and winter, so that if there is another surge, people have some protection already on board.
Yeah, I forgot to answer this earlier really quickly for the last question. So for pediatric transplant patients who are under 12, are you aware of the recommendations for vaccines for them?
Yeah, so unfortunately, this bivalent vaccine has not been approved for the under 12 group. And so the under 12 group is still operating under the original sort of recommendations, and which, depending on whether it's Moderna or Pfizer and exactly how old you are, is sort of a variable number of shots, actually. I have to like write it out by age group and shot type, but yeah, basically the recommendations for those under 12 are sort of unchanged from prior months.
Okay, and then the final question: do you see a time when COVID will not be what it is now for transplant and immunocompromised patients?
Yeah, that's a good question. I know it sort of feels like the rest of the world is starting to move on, but I haven't, it's not everybody. I do think there have been some major steps towards COVID being more like a cold than, like a serious pneumonia, flu, kind of thing, with Omicron, a lot more people just have sort of runny nose, sore throat, fatigue, and a lot few people, required hospitalization. And so I think we're making good progress. I guess it's transplant patients, I guess, always have to be a little extra careful, for infection, and that probably won't change. But my hope is that we'll continue to make bits of progress in terms of immunity and preventing really serious infection, which I really do think we have. We've really seen a lot fewer people in general, and particularly transplant patients, having to come into the hospital because of COVID than, back in the days of Delta. And so I think there's some reason for optimism.
Yeah, I think the first program you did for us was like August of 2020, or maybe even May of 2020, and then again. So it's certainly changed dramatically. The vaccines weren't even available back then. So yeah, I think for a lot of people it does feel like it's headed in a positive way. So we went over time, and we're so grateful for Dr. Anesi to take expert and answer as many questions as possible. And I know many people probably still have questions. If you would like, you can email me questions if they're general enough that we can provide resources. We can do that. I'll send a survey out with some resources, as well as also the AST website, so people can look for transplant-specific resources that way. And then eventually I'm able to send this recording out to those who couldn't be able to do so. Okay. So thanks again, everyone, for participating. Thank you, Dr. Anesi, and I'm sure we'll be contacting you again with things changing.
Yeah, anytime.
For your support.
Yeah, thank you for having me.
All right. See you later, everyone.
Bye.